Hello, ladies and gentlemen, and thank you for joining us for another session of Brain Aneurysm Foundation webinars. Tonight, we have our guest, Dr. Stanley Berman from William James College. He's going to talk to us about depression following aneurysmal rupture and subarachnoid hemorrhage. Unfortunately, depression is significantly underdiagnosed after subarachnoid hemorrhage and aneurysm disease. And that is a big problem because a lot of patients may suffer and not necessarily seek treatment. So tonight, I again thank you, Stanley, for joining us, and we all are very much looking forward to your comments. Please go ahead.
Thank you very much. It's a pleasure to be with you all. I'd say a few words of introduction in terms of who I am and what I'm bringing to the table here. I'm a doctoral, a PhD clinical psychologist. I am a specialist in health psychology, so I work with individuals who are living with challenging health difficulties. I was at the Children's Hospital and the Dana-Farber Cancer Institute for a number of years, working with medically ill children. Currently I'm a college professor and a college administrator at William James College. The one other thing I'd like to share with you is that I survived, fortunately, a ruptured brain aneurysm in 2011, and I required a stenting in 2016 for an unruptured aneurysm. So I have both worked in this field as a professional, and I've been in this field as a patient, and I wanted to share this with you. As Dr. Cohn-Gadol described, unfortunately, individuals following brain aneurysm may experience depression. The Brain Aneurysm Foundation invited me to speak with you to help you better identify what depression is, what it looks like, and what you might do to take care of yourself best in the event that you are experiencing or have experienced depression. So first, let's look at the lay of the land. A certain percentage of brain aneurysm survivors may experience intervention following medical intervention. The depression can range from being mild and short-term to being more substantial and ongoing. In the general population, meaning people who are both healthy and people who live with medical challenge, approximately 17% of us, so that's almost 1 in 5, experience a depression sometime during our adult life. So it's a frequently occurring disorder, and it's a disorder that responds to treatment. The World Health Organization projects that by 2020, which is very close to 2018 now, depression may be the second leading cause of disability after cardiovascular disease. It's difficult for me to share with you what's the prevalence in patients with brain aneurysm and AVMs, as there's no published studies. However, if we extrapolate from the data on stroke patients, we see that it's 14 to 19%, which puts us right in the comparison range to that 17% in the overall adult population. So that means that while we're not at higher risk, that it could well be that 1 in 5 of us may experience a mild to moderate to severe depression in response to coping with brain aneurysm. There's another confounding difficulty, which is that people may live with depression following brain aneurysm, but they're dealing with so many other adjustments that they may not recognize it in themselves. Their loved ones and friends and family around them may not recognize it. So I suspect that it's underreported in medical populations in general. So what do we know? We know that medical illnesses in general predict people will experience higher rates of depression. We know that depression is serious not only in the quality of one's life, but it may adversely affect treatment compliance. There may be a number of things you're doing following aneurysm, which could include physical therapy, it could include occupational therapy, speech and language therapy, and it could well be that one is not so compliant because they have less motivation. We also sadly know that one depression may predict a subsequent depression. But the good news here is that depression can be effectively treated and managed, and later on this afternoon, I'll be speaking with you about what some of those options look like. So the symptoms are familiar, I think, to most of us on this webinar. People feel a loss of energy. They may feel persistent fatigue. They may experience changes in sleep and diet. And I want to comment that this is bidirectional. Some depressed people may experience hypersomnia. They only want to sleep, while others may feel they can't get a good rest and sufficient hours of sleep. Similarly, some depressed individuals lose interest in food, which had been a source of enjoyment for them, and other people soothe themselves by overeating. In general, there's ahedonia, which means there's a lack of pleasure. One used to enjoy being with one's children or grandchildren. One used to enjoy going to the symphony or cycling or whatever the leisure activity was. And suddenly now one feels the blahs about any of these activities. There can be sadness and teariness. There can be no or low libido, which means that adults that have enjoyed a sexual interest in sexual life may feel that that's beside the point right now. That can have an impact on people that are in a couple where the partner is hopefully patient, but also hoping that there'll be a resumption of the pattern of one's intimate life. There can be a lack of concern or interest in things that used to be very important to you. In a smaller percentage of people can consider self-harm. What's the use? Do I want to keep pushing hard? I've sustained a lot of changes that are difficult for me. I always describe suicide as a permanent solution to almost always a transitory or a not permanent set of circumstances. That I believe that if people can be supported and get the proper treatment, that they can once again reinvest in life and don't have to make a dire decision and harm themselves. Often people who are depressed have a lack of interest in the future. Their self-care may decline, that the person that was meticulous about their grooming may not care so much about their grooming or how they dress or present themselves. And there can be a lack of feeling hopeful. So this can be a very substantial burden for the patient, but also for the loved ones around the patient. So we know that one of the things that can be a stimulus for a patient with an aneurysm or an AVM to feel a sense of sadness is that there's many losses that can occur for those fortunate people that survive their aneurysm and AVMs and have a next chapter in their lives. There can be a lack of trust that I can trust my body, that I can, I'm not a 39-year-old man, but a 39-year-old man, a 54-year-old woman may feel I always basically trusted in my body, and now every little sign and symptom I experience makes me apprehensive and fearful about what does that signify, what does that mean. There can be a lack of trust in one's cognitive functioning. Someone that was very well organized and planful may feel post-aneurysm that they're struggling with having that same level of efficiency and effectiveness, and this can lead to sadness. We all like to assume that we have a very long lifespan, and it's quite a startling wake-up call to survive an aneurysm and then have now worries about, well, how long will I be healthy and functional and fit? There may be a lack of trusting yourself that you can return to your job. And for many of us, there may be the thought of we have to dial back our occupational expectations, or for some of us, we are not able to resume our previous professions. And this is a very substantial loss because many of us identify strongly with our jobs and feel a sense of competence and confidence through our jobs. There can be fear of how will my family receive me. I'm having some trouble with organization, or I'm having trouble with depression, or my balance is poor, and will people step back from me? So there's a lot of major psychological issues that in the first 3, 6, 12 months post aneurysm or identification of AVM that many of us experience. To continue this not easy to hear list, but if I'm describing depression, it's important that I walk you through this. There's can be a loss of a sense of self-efficacy, a sense of agency, a sense of purpose. So let me uh, 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 take on this jargon that I'm presenting to you and make it more accessible to you. That many of us feel that if I plan to plant my garden this summer, if I plan to pursue and receive a promotion at work, that I know what I need to do it, I can build a plan, and I can effectively do it. This is a sense of I'm in control of my life. I have the rudder on the boat in my life. And often after aneurysm, when we've had some changes, it's natural for us to wonder, do I still have the power and the ability to meet my goals? In people with more difficult adjustments after aneurysm, I need now to get some help. I need to depend on a loved one or maybe a personal health assistant to accomplish some goals, and this is a very difficult adjustment for me. So we're worried about, am I changing in my emotional life? I know in my own early months I was highly emotional and I'm not a guy that cries, but I could cry without much of a stimulus. We're worried about, can we physically do what we've enjoyed doing? Is our brain our best friend, and can we think through and problem solve like we have? Can we regulate our behavior? And I think having such a frightening experience can also lead to fears about death. So what are some of the pathways for depression? There are people that are quite sad and have reason to be quite sad. And I'm describing this as non-pathological sadness, meaning you don't have a psychological or psychiatric diagnosis of depression, but certainly you're going through a period of sadness while you're depressed. We can then move on to the most mild diagnosis of depression, which is adjustment disorder with depressed mood. And this suggests that you're basically able to function as you envision, but that you're often sad, feel less pleasure, feel less connection, less energy. To people who then move into a major depressive episode that can last for a number of weeks or months, and people that live with depression and have what we call a dysthymic disorder, meaning that they tend to be depressed all the time. And in both a major depressive disorder, your functioning is disrupted for a period of time in different ways. And in dysthymia, that may be the case as well. So some things we should think about when we think about depression is, what's the age of the individual who's depressed? What's their gender? What's their partnership status? What's their diagnosis and treatment? So in this case, some of us have a surgical or other variety of now medical interventions, and they each have different recovery periods, and all these issues may affect us more. For example, a 27-year-old that sustains and survives a ruptured brain aneurysm may be at greater risk for depression because they haven't met all their life goals. They're perhaps still dating and they're seeking a lifetime partner. They're perhaps still building their career, and the changes that may be temporary or some may not be temporary post-aneurysm may put them at greater risk for depression than, let's say, a retired individual in their 60s. People that live alone and don't have as much support may be more at risk for depression. People that have more difficult consequences and what we call sequelae from their medical intervention may be more at risk for depression. So with depression, we consider biology and genetics. Some of us are more at risk for depression because of a family history of depression. Some of us may have some ongoing physical difficulties or headache or other issues, sleep disruption, and this can put us at greater risk. When we're talking about other illnesses like an emphysema or a cancer where there may be stages of disease, the more serious the disease presentation, the more at risk we may be for depression. And certainly for people, and this is more the case in, for instance, cancer or chronic COPD or other issues where we realize that we're closer to the end of our life. Many of us may sustain a depression at that time. What is some of what we call the moderating variables, the modulating variables, the things that make a difference? We do know that when people feel that they're embraced by a community of family and friends and co-workers that are checking in on them, spending time with them, helping them with tasks, rallying them and cheerleading, we do know that that's a very important variable that helps people. We also know that when people feel well connected, I can really trust my best friend, my life partner really understands me and is there for me. When people have entered this medical chapter and challenge with a higher sense of self-esteem, these are all things that can help be tools to better work with a depressive period or depressive episode. And interestingly, people that have a strong philosophical or religious or spiritual life often cope better because they have a framework that helps them think about, why did this happen to me and how do I make meaning out of this? I'm using the word spirituality and religiosity on purpose, meaning by religiosity, I mean the person that finds their Catholic faith or their Jewish faith or their Muslim faith to be a very important definer of who they are, and that community and that set of beliefs makes a huge difference for them. For spirituality, I'm trying to capture those people that have many important philosophical beliefs about the world and how it works, but may not belong to a formal faith community. So I want to talk with you now about one component of thinking about depression, and it's learning how an individual understands her health or his health. So if I'm working with someone after a serious health event like an aneurysm, I'm interested in how much does the person experience their symptoms from their illness, and meaning how much is the illness center stage for you about who you are at this point in your life. Sometimes an individual will still be very identified with their recreational work as an artist or with their other strengths and skills they have, and they say, and oh, by the way, I'm also coping with this neurosurgical and neurological challenge. Other people, their illness and its challenges may be front and center. So it's helpful for me to understand how much is coping with the aneurysm front and center. And I would expect in the early months, it's front and center for almost all of us. And then I think as people make progress and do better, that for many of us, it's on the side of the stage. And that's a good, healthy sign if that happens. It's helpful to know what the person thinks has caused their illness. And people that take on, often incorrectly, a lot of self-blame for where they landed often are more at risk for depression. It's interesting to know how long they think they'll continue to struggle with their symptoms. And the person that says, I think that this is my new reality, they may be more vulnerable to depression and may need a mental health professional to help them make this important adjustment. I'm interested in how does the illness affect your life? And for people that describe many consequences and feel overwhelmed by how it affects their life, and this is not simply a psychological perception, this may be a reality. Once again, these are folks that I think may very well benefit from professional mental health care and or if it's their want, pastoral counseling. How much do you think medical intervention can help your illness? So people that have great faith in their neurosurgeon, their neurologist, their primary care doctor often feel they have more control and more of a safety net. How much control do you have is also an important question, because people that feel between myself and my support network and my medical team, I'm able to figure this out, often feel more empowered and are at less risk for depression. So we talk about a course of illness, and this is a broad map, and it doesn't apply to all of us. We're very variable as human beings, have very different histories, and we don't follow a lockstep map. But my colleague, Dr. Sperry, who's both a psychiatrist and a psychologist, suggested a map that I think makes some sense. That often when we learn that we have sustained a ruptured aneurysm and need immediate intervention, or we learn that we have a non-ruptured aneurysm that's going to be followed, or an AVM, there's a period of crisis. How did this happen to me? Why did this happen to me? This is terrifying. How will I do? Do I have the best hospital, the best medical team, the best advice? And post-intervention, there's often a period of stabilization. We feel we're alive. We, in many cases, have a new reality where we don't have all our functions at the previous level prior to the aneurysm. For others of us who are fortunate, we return close to our previous functioning. But there's a period of stabilization, of things falling into shape, whether it's just a slightly different new reality or whether in fact it's a significantly different new reality. We then move towards a feeling of resolution, that here's my life now, and I'm substantially back to what it was, a year and a half ago, or I'm now authoring a new life because I have different capabilities now. And finally into a period of that's part of my history and that's part of my reality, but I'm back to living substantially the life I want to live. I find this roadmap to be a useful one as I think about us and the pathway we walk down. So you are listening to this talk and feeling, I've been resistant to getting help, but I may benefit from getting professional help. And there's obstacles. And one obstacle may be a feeling of stigma. People that are strong, that are capable, don't need to get mental health services. People that get mental health services are really crazy, and I know I'm not really crazy. I think stigma and mental health has improved dramatically in America in the last 30 years, but I think it still is there for many of us. And I would say to you that a depression is an illness in the same way diabetes is an illness, or heart disease is an illness, or flu is an illness, and that there's effective treatment for you. And I want to encourage you to push through that feeling of stigma and get the help that you will benefit from. Often people don't want to pursue things because they feel stubbornly independent, or they're in a cultural group that feels that the family helps, but that we don't go to outsiders for help. Once again, I would hope that perhaps with your medical care team, you could talk this through and recognize that you might not have to struggle as much if you would allow yourself to get help. Often there's a lack of knowledge about health insurance benefits. I know that we're in a very confusing, complex time in our national discussion about health insurance and who's covered and to what extent and by whom. In a number of states, there's a mandatory mental health benefit, meaning that if Blue Cross, for example, which is a popular plan throughout the United States, offers health insurance, they're required to offer mental health coverage as well. In other states, unfortunately, that's not the case. But it's easy to do a little web research and learn what's available to you. And then people sometimes are concerned about mental health services. I think my field has been parodied and satire has been made about my field, both with some deserved zings and also with some undeserved zings. And I think when people think about mental health from what they see in a romantic comedy portrayal or a sitcom on television portrayal, that's not the reality. And there's good, sober, serious professionals who are able to help you and are not the comic figure that you might see in a particular situation comedy on television. So, step by step, if you decide or you're encouraged by your medical care team or encouraged by your family to pursue care, you could ask your neurosurgeon, surgeon, your nurse, your primary care doctor for a referral. You want to see an individual who's a licensed mental health professional. In most states, anyone, regardless of training, can call themselves a therapist or a psychotherapist. You want to go to someone who's been licensed by their state board. There's many choices, and let me take a few minutes to walk you through these choices. Psychiatrists are physicians who have gone through medical school and have studied general medicine, and then moved on to do a fellowship and learn psychiatry. They can both prescribe antidepressants and other psychopharmacological medicines when they're indicated, and they can offer psychotherapy to you. Psychologists have a 5 to 7 year training and hold a PhD or a PsyD. They're licensed. They work with a psychiatrist or with a primary care doctor when psychopharmacology, when psychiatric medicines are indicated, but they're experts at both assessment of mental health issues and at the treatment of mental health issues. And they, like much of the field, works with what's called empirically based treatment, meaning we have research to back up that we're treating depression in way A or B or C because the research shows that these ways are effective. Psychiatric nurses may have a master's in psychiatric nursing and be called a clinical specialist. They may have a PhD in nursing, or they may be a nurse practitioner with a specialization in psychiatry. And in some states, the NP designation is APRN, Advanced Practice Registered Nurse. These professionals can both prescribe medication and they can offer psychotherapy. Incidentally, psychologists in 7 states and in the military can pursue a training and also prescribe psychiatric medication. Social workers and licensed mental health counselors have 2 years of training and then supervision following their formal training. And pastoral counselors are typically clergy who have gone on for specialized training. Any of these people can be qualified and effective, and what's most important to me is that someone in your community, your neurosurgeon or the nurse in that practice, your primary care doctor, a close friend says that Jane Hong, a social worker in the community, was dramatically effective to my spouse and she's worth a call, or that your neurosurgeon says, here at our hospital, Dr. Johnson, a psychiatrist, has been very helpful with patients in the neurosurgery service, so that if you can obtain that one endorsement from someone, I think you go with greater confidence. When you do go to meet them, I would argue that almost always you're seeing an ethical and competent provider, but in this particular field, if you will, the personal connection, the personal chemistry is very important. And in the profession, we understand this. So sometimes you'll have 1 or 2 interviews and decide this is a capable person, but not the person for me. And then you would seek a second referral. When you schedule a first meeting, you want to be looking out for that fit. Do I feel comfortable? And in the first 1 to 3 sessions, the person will ask you many questions to arrive at a diagnosis and make a recommendation. And the recommendation might very well be for verbal psychotherapy. And you may also discuss that you may be further assisted with psychopharmacology. I'm not a fan, personally, of only being on a medicine that helps you feel more energy and more clarity of thought and have an improved mood. That's very important and very, very helpful. My concern is that for those of us that have landed in this arena and are coping with the health challenges we have, that you want to talk to somebody to help you normalize some of your strong feelings and fears and concerns. You want to try to build a stronger coping toolbox. You want to try to figure out relationships which may have had some slight alterations and perturbations over time. So I think the combination for many people of psychopharmacology and psychotherapy is the ideal approach. In some interesting classic research in my field, people that took medicine alone felt more symptom relief quicker, and people that were in psychotherapy, it took longer. But when they took both a year out, and sometimes people are in counseling for not just 3 months, but 6 months and a year or more, that at the end of a year, people that had both were actually functioning the best and had the best resolution of their symptoms. So, some special considerations. And I thank you for bearing with me. I hope that this is helpful to you and of interest. There's a field within mental health called behavioral medicine or health psychology. And these are professionals that work, or liaison psychiatry. These are professionals who work with people coping with medical illness. If you can find someone in your community, in a large city, this should not be hard to find. In a smaller community, it will be harder to find, who specializes in working with individuals coping with medical illness, they'll be most prepared to move right in and be helpful to you. People may be in treatment for 1 to 2 months, and many people may be in treatment for 6 months and longer. People that offer cognitive behavioral therapy, there's a very nice research backing that cognitive behavioral therapy is effective. There's other forms of treatment which are also quite effective, but you might want to take a look at cognitive behavioral therapy. Another therapy that's well supported is what's called interpersonal therapy. And you could ask your provider what particular training and approach they use. Some people may be in their own individual treatment and decide, I'm really having trouble in my primary relationship, I'm having trouble in my parenting, and may concurrently, at the same time that is, also be in a couples therapy or family therapy. Sometimes children are very affected if their parent has sustained and survived a brain aneurysm and has seen changes in their parent, and sometimes the child may benefit from either family sessions or their own sessions. In any treatment, you want to talk about, well, what are our goals here? What are my goals? How will I know if I'm reaching them? And have a clear picture of why you're in treatment and how you'll know if you're making progress. We talk about what treatment offers in depression. We talk about remoralization. And what I mean by this term is you've had the aneurysm, you feel sad, I'm not going to be who I was, I'm not going to be able to meet my life goals, I feel very defeated. And if you will, we've lost a feeling of excitement and control and vigor about our lives. And remoralization means when we can once again say, I own my life, I'm excited about my life, I have pleasure in my life. We want to see significant symptom reduction. We want to see your sleep improve, your eating patterns improve, your energy improve, your libido improve. We want to see people regain a sense of, I'm driving the ship here. We want people to feel that even if there's been changes they have to adjust to, that I now have a new set of meaning in my life. I have a new reason that I wake up in the morning. We want to discover new pursuits, but also return to previously important pursuits. And we want to have a general sense, once again, of well-being. So I thank you for having this opportunity to meet with you and talk with you